All right, welcome to another episode of the Owens Recovery Science Podcast. Today, the knuckleheads are all back with me, and we're going to break down a new groundbreaking pilot study presented at the Academy of Orthopedics, Sports Medicine. Never get the name right. I'll just say it. AOSSM at the Academy meeting last weekend with how BFR is affecting bone, and talk about some of the pathways potentially that we think might be important, and how this can maybe set up some pretty cool research on down the line, as well as what we're doing clinically. We're going to answer some questions that have been submitted. If you want to ask us a question, go to info@Owens Recovery Science Podcast and send us a question. If we read it on the air, we'll send you a sweet ORS Earn Your Deflate t-shirt, one of the good type of t-shirts, not one of these crappy cotton ones that people always give away. And also, if you like us, please subscribe. And if you want more information, check out our blogs, check out our other podcast at owensrecoveryscience.com. So without further ado, here we go.
This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right, Ben, Kyle, Zach. What's up, fellas?
Good morning.
Everyone's in their home base right now, right?
Yes.
Yep.
Kyle, you're about to cruise a little bit further from your home base, but man, this dude's got it made. Like, being West Coast, he gets to go like do trainings. Like, I'm be in Frisco, I'll be in San Diego, I'll be in LA, and then when he travels, he's like, yeah, I'll do the course in New Orleans, or I'll do the course in the Bahamas. So I don't know how you freaking want it, man. I mean,
did you book one of the Bahamas for me and not
Little Rock, Arkansas, in a few days?
I just got back from Abilene, Texas, man.
Yeah, but you like it there.
I love it there. Yep, yeah. I do, for sure.
Yeah. Well, yeah, and I'm from West Texas, so the number one thing I did is get the hell out of that area when I turned 18. No offense, Dad, and no offense to West Texas. Love you, but can't handle the dirt and tumbleweeds. So, anyways, just kind of do an update of the last week or two and next week or so, what everyone's up to. Kyle, you go first, man.
Let's see. March had a course the very first weekend in March out in Phoenix for a group called Foothills Rehab. They've got something like 38 clinics under one large umbrella. Just took on a group over in Tucson as well called Proactive. We had a crew of about 35 at that. It was a lot of fun. They had a therapy dog there, a little puppy, pit bull puppy named Zeus, which was cool. So he was hanging out the whole day.
Did you get a tourniquet?
Made me happy at least. No, man, I couldn't do that. These animal studies, you know how us Californians are. We kind of get a little cringy when you start talking animals and
That's true.
Whatever.
You'll do it. You'll do it to your patients and older clients.
People, I don't care. Let's go for it. But I start thinking about my dog when you start talking about putting fractures on beagles and stuff. So
we had a special forces dog that was injured, like one of the hero dogs, actually.
Really?
The dog had a reputation. And we were able to get a pediatric cuff. It was at, I think it was out at Pope, that they were able to get on him, but didn't get to see it through because the dog had to go in for multiple more procedures, and they just kind of had to abandon it. But a pediatric cuff apparently will fit a dog's limb. Probably not like a freaking Chihuahua or something, but a good dog, it will. So, all right, man, my bad. Keep going.
Cool, man. Yeah. So then a weekend after that was back in Phoenix for Milwaukee Brewers. I learned a little life hack about picking hotels that week because you need to really find out where the nearest Starbucks is, because if there's not one within like 3 miles, you might not be in the best part of town. I'm just saying.
You're a California life hack.
Yeah. I'm just telling you, I figured this out when those guys found out where I was staying. They were like, "You're staying where? And you walked where?"
Well, Kyle, let me follow that up with this. Is there anywhere?
Here we go. Are we talking about China now?
No. Is there anywhere in California that doesn't have a
snacks?
Starbucks within 3 miles?
I don't know that. Not where I live.
Okay. Yeah.
I'm just saying, that was the thing that, in hindsight, I thought, I could have looked at that. So, future reference.
I learned in Tampa when I was out there with the Yankees. They drove me and dropped me off at my hotel. And if you pick a hotel and don't look where it's right next door to 2 strip bars, that's also not a great area.
Yeah, there you go. Yeah, that's a good another good little life hack.
And the hotel seems to be used by a lot of people who like to frequent those places. So
I imagine so.
Which
Hourly
is why you
rates.
chose it?
it was a total accident. Total accident.
So yeah, man, I had the Brewers and then had a week off. I was in Abilene last weekend, did a course at my alma mater, Hardin-Simmons University. Had some good Texas barbecue. They actually have a good barbecue spot in Abilene now called The Shed, which is excellent. And then leave tonight for Oakland to do the Oakland Raiders, and then quick trip, man, up there tonight, then back tomorrow night, and then clinic 10 hours on Friday. So looking forward to sleeping this weekend.
Nice. Good. Yeah, now the Raiders were almost completely done with working with the entire NFL, which is sweet. I think we're like maybe one team shy, so I won't call that team out. But good stuff, man. So, Hardin-Simmons, the mighty tumbleweeds, right? That's
yeah. Exactly.
One of the top football teams in Division 9A.
Yeah.
Zach, how about you, man? What's been up?
Oh man, so a couple weeks ago I was up in Boston at Northeastern and did an open course up there. I had folks from Lake Placid Olympic Training Center, and then from Brigham and Women's Hospital, Mass General as well. It was pretty cool to talk to some of them about the BFR trial with the ACL repair.
Just presented, right? Just presented.
Yeah. So one of the guys that was there actually treated a couple of the patients there. So from his standpoint and from what he saw, it looked like some of the outcomes were really good. So
you want to expand on what the BFR trial is for people that might not know?
Yeah. So it's the bridge enhanced ACL repair, and so instead of reconstructing it, literally what they do is they go in and put a sponge graft in with growth factors to literally kind of bring the two ends of the ACL back together instead of reconstructing it with quad tendon, patellar tendon, or an allograft. So from basically the trial that's going on up there, I think they're around 4 years in. They've already kind of done, from what I was told, they've already kind of done the pilot data on it, and then now they're wrapping it up into a randomized controlled trial with hamstring allografts, or autografts. I mean, so yeah, the guy that I talked to, it sounded like things were really promising and coming along pretty well.
Yeah. Their session was actually right before the BFR session at the Academy meeting last weekend. So that would have been a good session to be on.
Yeah, so there was that course, and then just last weekend, went up to Pittsburgh to the Penguins training facility to do a private course with UPMC, and really cool with them. So we had people from pretty much all over central and western Pennsylvania in attendance there. I think one of the great things with that was they're bringing BFR to more rural populations in Pennsylvania. So kind of about an hour from where I grew up now, has multiple facilities with BFR. So it's pretty cool, to see that and branching out into kind of, you could say, an underserved population.
Yeah, that's neat seeing it go that way.
Yeah, and then what's that?
I was gonna say that Lemieux complex is pretty awesome. We got to go.
Yeah, man. Yeah, it's pretty crazy. So the way they move is one side is the Penguin side, and then the other side is the UPMC side. But it overlooks the rink. So I mean, when you're doing therapy, you can literally see the Penguins practice and whatnot. So, and then this weekend coming up, I'm headed to Fort Campbell to work with the military folks up there. So should be pretty good.
Nice. Yeah, that's awesome groups, man, from Mass General folks, Lake Placid, UPMC. It's funny, like, these trials now, when you get a big one, everyone wants you to come up with a sexy name, a sexy acronym. The BFR trial, the Moon trial. So at UPMC, we have a massive, I think it's 27 sites are doing a multi-lig trial. It's not a BFR specific trial, but it's a multi-lig, aggressive versus non-aggressive. We have a part of it here with the DoD, and we were trying to come up with a name for it that was sexy. J.R. Gang was the guy who put this one out because it's MLKI is multi-leg knee injury is what you normally say. So he wanted to call it the Milky Way. But it got voted down. No one wanted to go with the Milky Way. So we don't have a good acronym, man. We're still working on one. Because when you present, it better sound something cool like that. Ben, what about you, man?
Yeah. Past few weeks, I've been in Ohio and Troy, Ohio. Did a course over there, and then here fairly local in San Marcos with Texas Physical Therapy Specialists. And then just this last weekend, made my kind of biannual trip to the Twin Cities. Was up in Minnesota, so still cold up there. I mean, that's a huge surprise to everybody, I'm sure. But yeah, it was still a bunch of piled up snow on the ground. I mean, we got, it was pretty when I was there. I got up into the kind of low 50s during the day, but it still had all these big snow piles on the side of the road, which was interesting for a Texan leaving 75-degree weather and going up there to snow piles. But yeah, it's I actually have my first weekend without a course this coming weekend. It's strange. I don't know what I'm going to do with myself.
Yeah, I think all you guys are home. I'm the only one working this weekend. What the hell?
I'm working.
Oh, all right. My bad.
Yeah.
Oh yeah, you're at Fort Campbell Monday, right?
Yeah.
Nice.
Fort Campbell, Army. What's Fort Campbell?
Ben, what's that, Kyle?
It's Fort Campbell Army. What's Fort Campbell?
Yeah, Kyle. Any fort is typically an Army base.
Yeah. No freaking military dudes in your language. I have no idea. So what do we got? Forts or Army?
Camp. Camp is a Marine Corps base.
Yeah.
Okay.
That wasn't even an acronym.
Yeah.
No, y'all have a whole different language that I have no clue about. All right, so then what's Navy? They're just out on the water?
I mean, they don't typically have like something that comes in front. I mean, like Little Creek, Dam Neck. Yeah.
And then Air Force? What do they do?
I don't.
Yeah, there a lot of jokes might come from that, but
And then
from a Marine,
Motel
so
6.
we'll be careful here. Yeah, but Fort Campbell's. So we've already been there. I've got a lot of good friends up there. Fifth Special Forces group there, as well as Kyle, who we've worked with in the past, and then a huge, massive clinic space. Again, not my favorite city in the world there, but it's close to Nashville, which is cool. So there's good barbecue. At least you get some good barbecue. And Ben, I got to throw this shout out. Ben's been invited to be the keynote speaker at his graduating class from his school, man. So what is that, next week, Ben?
That's in May, and it's just at the graduation dinner. It's not at the full on ceremony.
Oh, okay. You're getting
it's not as
now he's humble. He can walk into the. I'm like, boom! Guess who's keynote speaker? I'm gonna be on TED Talks.
I didn't. Oh man. Goodness gracious.
All right. Well, and I'm off to my annual. Well, I think you did it last year, Ben. But every year we do with the Arkansas Physical Therapy Association, we do a course out there, and majority of the proceeds go back to the Arkansas PT Association. So I'm there this weekend out at the Arkansas Medical School, which is good. This thing's crazy. I mean, if you look at our most trained state of people that are certified providers, Arkansas just blows it out of the water. So if you want some BFR and you're in the Arkansas area and you're a patient, you should be covered, because I think the state's doing great there. But good people. We're discussing a multi-center total joint trial between Arkansas and University of Colorado. So I get to meet with them on that, which will be really cool. And then I'm off after that to the American Physical Therapy Association's Orthopedic Academy Conference out in Denver, which is going to be sweet. And then working with the guys at Next Level at a course on Sunday. And I guess we got to put it out, man. That course is almost sold out. I think capacity was 40. We just got a few slots left on that weekend too. Houston, is it sold out, Ben? I mean, it's pretty much
that one's sold out, and then we've got Zach doing a giant private course that weekend also.
Yeah. So
yeah.
If you're trying to get in on one of those, I would do it. Well, I guess the only one left now is Denver, and there's only a few slots left. But if you want to do it, it's a great facility, great people. It should be a good time. All right, so let's get into the nitty gritty now. So the biggest orthopedic conference, maybe in the world, but definitely in the United States, is what they call the Academy meeting, the American Academy of Orthopedic Surgeons, and they just had it out in Vegas last week. And then off of that meeting, you have a lot of breakouts. So the American Academy of Orthopedic, the Sports Medicine Society, the Trauma Society. They have these kind of little break offs, what they call specialty days, which are probably even more attended. And so a couple of BFR presence there, which is nice, because typically, no offense, but they kind of don't really give a rat's ass a lot about all the rehab talks. And there's rarely rehab talks. It's more orthopedic driven. But Dr. Robin West's group in the Nova had a cool booth type poster session set up on how they're doing BFR with a full demo, like video going and everything post surgically. And then again, I think we talked about them a few weeks ago. Freaking Bradley Lambert, man, crushing it right now. So we've been kind of, just in collaboration with them. And we've known those guys for a long time. Bradley, back at the Center for the Intrepid, he and Dr. Mike Marino from A&M came and visited me, and we discussed kind of some study ideas a long time ago, and now they're finally coming to happen. But he had the initial pilot data from one of his randomized controlled trials that he was able to present at Specialty Day, and it was such a big deal. The AOSSM actually sent out a press release to announce the day of about his talk, and the title I don't have it in front of me, but it was something like "Blood flow restriction may improve bone healing after anterior cruciate ligament surgery." So that was cool and good for Bradley to get that out there. I think he had 1,100 surgeons at his talk. From what one of the docs said that told me about it, and so here's the gist of it. We got a couple things out of this study, and it's not done. They're wrapping up the last few subjects, and then it will be submitted for publication. It will get picked up for sure. But what they did was, basically BFR 2 times a week, starting day 10 after ACL surgery, and they did that up to the 12th week. And they had a work match control group that did the same exercises without BFR. And we'll go into all the guts of the study, but it was kind of a staggered approach at that day 10, that first, weeks 1 through 3, I think. The BFR group just did straight leg raises with BFR. Control group did the same thing without, plus all their other protocol exercises, again, doing the same things. They used 80% limb occlusion pressure, and Bradley, and this is the way we want everyone to kind of think about it, and the way we have to set up some of our studies. Our total joint studies is the way we're setting them up to make sure we follow it. You don't always have to start at 80, and we'll talk about why getting that higher pressure might be important. But typically, they start at 70, and then we'll progress up to 80. And as Bradley, we spoke several weeks ago about it. Almost every patient tolerates an 80% pressure after a week or two, but you might have to build them up to it. And then after that first bout of basic kind of mat exercises, then they went to like a bilateral leg press with or without tourniquet on, some eccentric leg press, hamstring work, and then progressed to more single leg stuff by rounding up into the 12th week. And so they were using DEXA to measure for changes in lean muscle mass, but they also were able to pick up on that changes that happen in the bone. And so what was very, very fascinating, and this hasn't really been published, and I talked to some docs out at Extremity War Injuries about it when we first were looking at the initial results, is the fact that the involved limb, the bone went pretty osteopenic, that it started to lose bone density, and a lot of bone density down around the distal femur, the tibia, at the joint itself. And what Bradley and them found was even at the 12th week, it was getting worse. So at the 6-week time point and the 12-week time point, they measured and looked at bone density on these DEXAs. And if you're looking just at the control group, at the 6th week, the bone was kind of going south. And at the 12th week, the bone really was still going south. It was still getting worse. And so what we don't know is, like, when does that switch? When does that change? And what they found basically in the BFR group is not only did they preserve the lean muscle mass, and the BFR group was doing significantly better in keeping muscle on the thigh, but they did significantly better at the 6-week point and the 12-week point in attenuating that bone loss. At the 12-week time point, basically, especially around the knee joint, the bone was basically almost back to baseline. Let's see, I do have, this is from earlier pilot data, so I don't know exactly, I wasn't there to see exactly what was presented, but if we're just looking at the distal femur, at the 6-week point, the BFR group hadn't significantly lost any bone density. At the 6-week point, the control group hadn't, but at the 12-week point, they did significantly have a loss of bone density. So at 6 weeks, it looked like it was trending down, and at 12 weeks, the bone had significantly gone down if they didn't have the tourniquet on. Basically, at the 12-week time point, the distal femur in the BFR group looked like what the femur had looked like in the control group. And then the tibia, it was basically pretty much preserved almost at baseline in the BFR group at both 6 and 12-week time points. At 6 weeks, it was down, again, worse than the BFR group at the 12-week time point, but not significant in the control group. And then at week 12, significantly different between groups and significantly down in the control group. So this is interesting. That is something that we don't talk about, is the loss of bone that might happen post-surgically, just from limited use, maybe from something that goes on from the injury and surgery itself. So you guys have any initial thoughts from that? And the interesting thing is the whole thing was about preserving lean muscle mass. And now no one's even talking, that's almost like a no duh. We knew the BFR group would have more muscle, and they didn't check strength in this. They checked functional measures. At 12 weeks, the BFR group was significantly better on their functional measures they did. But the bone is now what's got all the hot kind of press and everyone talking. So you guys, what are y'all's thoughts after that?
Yeah, I mean, I think you look at it and it just kind of makes sense, right? So we go into this surgery. Typically, even if your weight bearing is tolerated, you're in an altered weight bearing status. You're not going to evenly distribute weight through that limb. And then the other thing is too, when it comes to loading, I mean, everything we know about bone is it's kind of load dependent, right? So we have to put load through the bone, and post-operatively, we can't put load through the bone. So yeah, I mean, it just, seeing it now, it's kind of like, yeah, this makes perfect sense. Like, we absolutely would anticipate to see this. And I think the thing of it is too, it's just like you said, at 12 weeks, the control group is still going down.
Yep.
There's no reversal at 12 weeks. And so now the thing of it is how much longer does this go down before we start to see the actual reversal and start to build bone mass back up?
Right.
Yeah, I thought one other thing that was kind of interesting, and again, I think we're talking about a really small sample, so you don't know if this evens out over time. But when you're looking at the control group out at 12 weeks in the uninjured limb, that bone density was better than the BFR group. So you kind of wonder, like in that BFR group, if they're just not moving around quite as much as they typically would. So we're seeing bone mineral density and bone mass kind of stay the same, but in that control group where they're uninjured, if they really seem to be moving around a bit more, but they're really loading that uninvolved limb more and more, and so you're seeing kind of that reaction of load just there. But was really kind of curious, and I was also sort of wondering, Johnny, when did they start looking at bone mineral density? Did they do any pre stuff? Because I know the information we have here is just at 6 weeks post. So I was kind of curious, well, when did this bone loss start? Do we see it track similarly as to muscle? I mean, we got to imagine that bone and tendon are responding similarly to the removal of load or removal of signal like muscle does. So I was just kind of wondering, when did that start?
Well,
and then also that
baseline 6 week and 12 week is
okay.
Is when the measures were done.
What we've got.
So
okay.
that's the time points we have. So we know at baseline at 6 and 12 weeks, the control group lost it. So that's what we can say right now.
Yeah, I mean, Kyle, I'm sure we can assume that the baseline is that 0 on the y-axis, right? That's going to be where everything moves from. So
Yeah, I was just wondering, like, are we seeing any change in that, particularly from start to 6 weeks? Was there any change there in bone? Because we just didn't have it. So,
Well,
um,
yeah, it is showing it, right? That's the 6 week mark is what is the change from baseline
I
on
think
those
what
graphs.
Kyle's asking is when was the initial measurement, the baseline measurement
it
taken?
was taken at six
Like,
weeks,
was
right?
it,
Baseline was
yeah,
at 6.
No,
Yeah, so we don't have.
baseline was
baseline's
pre-op.
the start,
Yeah,
pre-op.
yeah. Baseline was pre-op, and then the first follow-up, the first data collection was at 6 weeks. Second data collection was at 12.
Right. Well, okay. So, and let's get back to this point again of what we're kind of looking at here with bone. So that's the fascinating question. So for one, we got to think about now that post-operatively, in a younger, healthy population, the bone is making negative changes, which again, no one's really talked about. Dr. West and I were discussing this too, and she even said, sometimes if she has to go in for any second procedure, she's noticed that the bone just feels softer. After they've had a procedure and had several weeks or longer, it's like, yeah, we as surgeons know that the bone doesn't seem to have the same density from what we remember going in on this person before. But then the big question is, what about the more compromised individual? So the total joint, especially the female total joint, who's gone through menopause, and we think the bone is probably more osteoporotic, even maybe moving into this. This is really fascinating. Is this something that can increase bone density in those groups and maybe help with incorporation of the prosthesis, maybe slow revision rates? So, the big question that spun out of this was, okay, is this something also that can maybe push graft incorporation quicker with an ACL? If we're getting more bone density, especially around the joint. It wasn't right under the cuff. The whole limb bone density improved, but also looking specifically at the joint, does that change maybe graft incorporation? What do you guys think?
Yeah, I mean, it seems like it would, right? I mean, and that's, thinking about the aging population you're talking about and these changes that we're seeing in the bone, it seems to be obviously tied to decreased stress, like we talk about with anabolic resistance in muscles. So, this is the thing that really changed for me with, the more we get into this information, kind of looking at all the ways we can chemically mediate changes in bone as opposed to thinking of it as only being mechanically mediated. So, it just really seems like some of the things that we can make happen with this just make total sense. It's just getting the big trials to back it up.
Yeah. So that is the next setup from a clinical question is can we look at changes in how quickly we get graft incorporation, and maybe a kind of pseudo ligamentization of whatever graft. These were bone tendon bones that they used in all of these subjects. So you do have a bone plug. You are waiting for this incorporation. So that was kind of the spinoff questions from a lot of the docs there. Is okay. That's awesome. And again, the lost point is that the muscle was significantly better in the BFR group at these time points as well. And so that's this kind of double win. And then what's really interesting, and we've been kind of harping on this, and the ISR guys really were pushing this hard on us, is bone and muscle, there's a crosstalk, and they have to work together. And so if bone isn't responding well, if bone is unhappy, the muscle is going to be unhappy because everything comes from bone. Not everything, but bone is really important in feeding the muscle what it needs. So it feeds. We have these progenitor cells or stem cells that live within the bone. We have HIF1A that gets activated, which VEGF kicks back in, and you get this capillarization or angiogenesis, which feeds the muscle and feeds the bone. And then if you think about it from an orthopedic structure standpoint, you tear a muscle and the muscle will just go into fibrosis. That's the way a muscle likes to respond. It doesn't regenerate unless now, we're looking at ways to promote regeneration by slowing fibrosis. You tear a ligament and the ligament will not do a direct heal. We're looking at the bear trials using patches, or you have to actually go in and just create a new ligament. You completely tear a tendon, the tendon does not heal right back. But you can have a pretty significant break in a bone, and the thing the bone does is like, I'm going to heal this mofo, right? So it will go in and it will heal itself, and not only does it heal itself, it comes back and heals itself bigger and stronger. You get a callus formation that's bigger than it was before. And so bone is very good at taking care of itself and healing because it has a lot of other things that it needs to do. If the bone is osteoporotic or is having to worry about itself, does that compromise what it's given up to the rest of the muscle itself, to get muscle back into a good place? Brad wanted us. He said, that's the thing that he was really bummed about, is he didn't get to speak on the muscle bone crossover or the crosstalk. That's so important, and where this might really be kind of more groundbreaking, because you only get 10 minutes at these talks. So I think that's maybe going to be more fascinating. Is we can't just look at muscle or bone; they go together, and maybe a happy bone makes a happy muscle.
Yeah, I mean, agree with that, and I think the conversations we've had kind of off this podcast is it looks like a lot of these, cellular responses that we need for remodeling of tissues in general, talking about, all the tissues you mentioned, seem to really stem from the bone, everything from those, hematopoietics that differentiate the different cells to the macrophages to, that HIF1A and angiogenic response. So it looks like the bone is obviously a key player for everything that's happening around it.
Right. And we have bone data, but it's not a great clinical model. So if you say, well, is there any BFR, mechanistic data that supports its effect on bone? There's animal models out there that have shown us that, but they're on a beagle, they're doing BFR or putting tourniquets on these dogs multiple times a day, and these are older studies in JBGS and JOR, which show that we do get union in the tourniquet group and the non-tourniquet group. These are pretty big osteotomies they put on the beagles. They had non-union. And then mechanistically, we can say, okay, well, there's all these factors. We talk about this in the course, interstitial fluid flow, the pressure between bone and muscle. There's this crosstalk. So the tourniquet might restore that, where it's almost like in a weight bearing. If you take a rat and hold it up by its tail, interstitial fluid flow is going to drop down, and that's why you demineralize. That's the whole NASA problem with non-weight bearing. And then growth hormone, we can get a growth hormone response. We're still trying to figure out everything growth hormone might do clinically that's helpful. But there's receptors for GH on bone, which can also help when positive bone changes. Bone-specific alkaline phosphate goes up in BFR groups and heavy lifting groups, but not in the light lifting groups. And that might be directly related to myostatin going down, which we've seen in BFR trials. We can make myostatin go down. And then maybe, again, one of the more powerful ones is VEGF goes up. It looks like when you go put a muscle into hypoxia, and whenever you put a muscle into hypoxia, when VEGF goes up, that's also a significant bone healer. So mechanistically, it's there. The problem is then you're trying to translate from animal models. Now we can say, well, this is very clinically easy, right? 10 days out, which is when most of us are starting BFR. Some people started earlier, some people started later, but for these routine ACLs and things like that, 10 days out and up to the 12-week point, twice a week, very clinically doable. And you've preserved the lean muscle mass and you've got the bone almost to baseline. Then it's a nice transition off of that. So I think that's a nice setup, is it's actually a clinical model where we're not like, well, damn, how do we translate this from a freaking rat to it? And so that's what's beautiful right now, is we have these clinical models coming.
Right. I mean, that's only slightly easier than what they did in the Hewitt study for the beagles with the osteotomy. I mean, they did the intermittent pneumatic compression 5-minute rounds, and they did it 100 times a day for 8 weeks.
Yeah. And you're like, hey, it looks like it works for bone. And, everyone's like, well, how the hell are you going to repeat that? And that's a over 10-year-old study. And that's probably why everyone just kind of looked at it and kind of ignored it. But you can't ignore that, okay, there's something there pathway wise.
Yeah, we just need people to walk around with a tourniquet on their leg and, tourniquet in a backpack, and it just inflates off and on throughout the day. And
yeah, well,
there you go.
don't hold your. I mean, I'm not gonna say don't hold your breath. You never know the way things are going, man.
Right.
So you guys
That's
have
basically what you did with your wrist, right, Ben?
Yeah, I mean that's the way I approached my wrist. I hope the doc isn't listening right now with my my scaphoid fracture that I was supposed to do nothing with for.
You just did that to just do your own little experiment. We know how this actually went.
Well, yeah, I mean it
was
was
kind of like that Alfredson's tendon protocol where you just try to rupture that freaking thing, and oh, what do you know? It got better.
Yeah, I mean, after the last scaphoid fracture I had, where I was 10 weeks in a spica and everything went to trash, and that wrist didn't feel good for about a year and a half afterward. I figured, what's it going to hurt to provide a little extra stimulus? So anecdotally, it felt better, healed faster.
You said spica, and it just triggered me a little bit because when I took the board exam after PT school, there were at least 5 questions about a spica. And we at no point during my education covered spica. And I just chose that by chance because I thought, well, it's got to be that process of elimination. And I mean, I passed, so I guess I did okay.
Well, I don't know that we ever. Yeah, I don't know if we ever talked about it in school, but I've been injured enough in my life. I seem to know what these things are.
So any other parting thoughts on this study where you think we should see research moving with it? Anything from y'all's side?
Yeah, I think go ahead, Ben.
All right. I was just going to say, I think it's obviously it'd be great if we could get some sort of animal model where they can actually look at, the incorporation of the graft or how that graft heals with the bone tunnel and things like that. If we're actually getting significant change there, because you're never going to go back and do that in a human. So actually seeing what the difference is for healing in the joint would be fantastic.
Well, but I think you can in a human through imaging.
Right.
So that's doable. It's expensive, but
right.
But the best thing about this is now we got pilot, and so that's always a question when you're writing these grants proposals. It's always like, show us your pilot, show us your pilot. Well, now we've got it, and I'll say there's and it wasn't 100% directly related to this, but we're going to have more. So the DoD just funded a stress fracture trial last month. John Mason is the PI on that. And we also, Jenny Hugh, who's an orthopedic surgeon, who was also with us down here at SAMC, she just got an ankle fracture trial funded with BFR. So nice. We've got those two in the DoD. We have the repair trial, which is the massive monster trial with now I think we're at 11 centers that is looking at changes after femur fracture with BFR. We just had a wrist fracture trial from our base as well, presented to the American Hand Society. That one we didn't look specifically at bone healing. We didn't have enough numbers, but one of the things was looking at is, does BFR make the pain worse in these individuals after bone fracture? I had an NFL guy years ago. We did it. He was rolling into the Super Bowl and did it on his fracture right before it, and it really made his pain worse. So probably started too soon on that one, or maybe the pressures might have been different. It was at 50%, but this one we showed at this Hand Society meeting, the pain was significantly down in the BFR group in these wrist fracture, and these were elderly wrist fracture individuals, and their functional scores were all significantly better in the BFR group. So a lot of bone will probably be borne out in BFR trials moving forward. So I think it's going to be something that's very interesting. And again, that's what's awesome. If we as rehab professionals can kind of say, look, these bone injuries, we can see them in the clinic, and we have something that might be a positive change. It might help with bone healing rather than spin your wheels. I mean, like these freaking stress fractures, we have tons of them in the DoD. And, it's like, okay, they go to the pool, or they walk on the Alter G, they're walking around dragging their crutches, doing little mat exercises. Well, now it's like, get in here at least 2 times a week, and we need to see if we can start pushing bone density. And oh, by the way, while you're doing it, we're also going to be maintaining your muscle and hopefully adding some strength to this as well. So that's
what I think's so fun about all this BFR stuff is it really kind of gets you forecasting a little bit at some point, like down the road. what does rehab look like? Do we really kind of program this differently, or are people in at different time points? And hopefully we're thinking at a different level. Like we're thinking at that bone level, at that myogenic stem level. What are we really trying to manipulate, and how are we decision making with it? I
Exactly.
think that's what's so fun.
Yeah, and that's the thing. It gets thrown in this like bucket. Oh, just go do your BFR, and it's like, well, okay, what are we
Yeah,
doing?
no way.
And
Yeah.
maybe, it's kind of funny because it's like, well, what did they do? It's like, well, they did, the same protocol that we do, 80% limb occlusion. They did 30, 15, 15, 15, 30-second rest. And so same low load, but as clinicians, we're going at it from this different perspective. Like, okay, this person's coming in and I'm doing this and I'm really doing it for this bone response, or I'm doing this because I'm trying to slow atrophy, or I'm doing this because I'm trying to spike progenitor cells because they're about to get a PRP injection and they need this progenitor cell spike because I want to supercharge that injection. So it's very standardizable, very easy to reproduce as a profession everywhere if we follow those rules. But we're looking at these different pathways that we're attacking. I had a doc mention at one time. He's like, this is what he thought was cool about BFR was he's like, it seems like everyone does something different whenever they go to rehab, and I never know exactly what they're doing. But when I know I'm sitting these guys, the people you work with, I know they're getting this percentage, they're doing it this way, and it's very standardizable. And I'm hoping to get the same results that you guys have been seeing with it. And he said it reminds him of an injection. An injection could have the freaking most hardcore cancer drug, or an injection could be a steroid, or an injection could be a placebo. It all looks the same, but you're doing it for these specific reasons, and it's very standardizable and reproducible. And I think that's something that we might be able to kind of hang our hats on with this. So I think it's cool. I'm fascinated. I've been preaching this bone and muscle crosstalk. Dr. Ben Corona and Josh Winke and all these guys at the ISR. They've been talking it. It's almost like where we were with the muscle and tendon. Long time ago, it was like it's muscle and then it's tendon. And then we found out there's this musculotendinous junction, and it's kind of wacky world. And there's this, they kind of merge into one, almost like this kind of webbing, and there's a lot of wackiness that happens there. Now it's, there's specific people who are looking right at what's the bone muscle crosstalk, that they kind of merge into working with each other. So we have to respect both of those have to come along to make change. Okay. Then let's talk about Grant's paper. So Grant Mouser, he was at Ole Miss. Now he's at Troy. Great guy. We're on the from the lab to the clinic paper. He was with Jeremy Lineke's group. Done a lot of good BFR stuff. So what he's looked at recently in a paper was, does low pressure, 40% limb occlusion pressure, arterial occlusion pressure, or personalized tendon or tourniquet pressure, whatever you want to call it, does it create the same response at the vascular level for a positive effect as a higher pressure, 80%, or lifting heavy, 70% of 1RM? So have you guys read that one? Anybody want to kind of break it down of what Grant found?
Go ahead, guys.
Nobody at once. Not everybody at once.
I just talk too much. I make everyone nervous.
Oh, that's too funny.
Well, basically, same easy protocol to repeat, but this isn't a clinical trial. But they did 2 times a week for 8 weeks. And so 3 groups: low pressure in the arm, low pressure in the leg, high pressure in the arm, high pressure in the leg, or a heavy lifting group. And basically what they wanted to look at was, what are the changes at the vascular level? And so vascular conductance. The exercises, they did these at 50% of a 1RM. And so basically what Grant found is, at the low pressure, they didn't see changes in forearm and calf vascular conductance. At the high pressure, they did see positive adaptations in forearm and calf vascular conductance. So basically right here off of their discussion, the unique finding of our study was that both forearm and calf vascular conductance increased in the very low load, high pressure condition, as well as the high load condition. And these were not statistically significant from each other. The low load condition at the low pressure, we didn't see these changes. So we know that we can have positive adaptations with angiogenesis, with improved vascular conductance whenever we lift heavy. And so there's a couple of ways to look at it. So bone, again, is more hypoxic. If you go into muscle and make it hypoxic, we get the kind of downstream effects of HIF-1A into VEGF, and VEGF is very powerful angiogenic response. But also the mechanical compression kicks in this ENOS cascade. And so if you can mechanically compress a vessel, then that also creates positive adaptations in the conductance of these large vessels as well. And so what Grant found was you can make this happen if you go have someone lift heavy, or you can make this happen if you have someone go lift under a high pressure and lift light. But these lower pressures, they didn't see these adaptive changes there. And so that's very interesting, because if we're talking bone, these pathways, we have a paper that we talk about in our course. I think the title's like VEGF, the key component for bone and fracture healing, or something like that, right? So, when we were first looking at VEGF at the ISR, these guys are like, yeah, everyone's trying to find a VEGF vesicle, either through pharma, through injections, that you can drive this upregulation to maybe help with bone healing. Well, or we can put the limb into hypoxia and put mechanical compression on the vessel and potentially get these same adaptations. So these basically, Grant's paper came out right at the same time that Bradley's paper came out. And I think the key points are, yes, these are things from Grant's paper from a lab that show that they should help in with what we see happening at the bone. And high pressure, 80% made it happen, 40% didn't. In the arm, and this is what's interesting, makes us have to think, it was 80% in the arm showed the changes. Right? Ooh, man. Well, then I always want to be there like, dude, how are your people handling that? We started 80% of the arm, and most of our patients didn't tolerate it. I think, Kyle, you're answering some questions on the inner circle. Someone is saying, yeah, we got some patients who can't tolerate the arm. You're like, are you at 80? Because most people, if you accidentally do it at 80, they just don't handle it. So clinically, that just might not be tolerable, especially, if you have like an elderly wrist fracture or cuff or something like that. But in the limb, that's basically what we know and the lower extremity, that's what we're doing. So that fits perfectly kind of into our protocol there. And again, nice again, 2 times a week. It falls right into it.
Yeah.
Well, this really makes me think about the Lisandro paper, where they're looking at different loading schemes and different pressures, where the lower the load, the higher the pressure probably needs to be to get the response we're shooting for. And with a 15% of 1 rep max, that's obviously really low on the spectrum of loading. So, it makes you wonder if there was a little higher load, would the pressure, come down and still get the same response? And I remember starting to do this on upper extremity when I was interning at CFI, and that was still 80% on upper extremity back then. And that was nowhere near as fun as 50%.
No joke.
It was not a whole lot of great stuff feeling in that upper extremity. I was doing a bunch of bicep curls, so that was probably me being a meathead back then, and that was even just a dumb choice altogether. But
well, that was the classic line from one of our OTs, because we were doing it, we were just so swamped with all these lower extremity injuries. We were primarily doing on the lower extremities, and I was having our folks do it at 80. And that was just based on, what early data we could get and some of the mechanistic stuff from our scientists at ISR and our OTs. One of them came down and she's like, our patients say they can't feel their arm and they can't really hold the weight. Is that what y'all are seeing with the leg? And I was like, no, I think this is a problem. So we kept taking the numbers down, and 50% seemed to be doing just as well from our pilot data as 80%. Jeremy's group had a paper that showed from a strength and hypertrophy. I think it was strength and hypertrophy. I can't remember. But it was, 40 did just as well as 90 in the upper extremity. The lower extremity seems to be different. But
I was trying to remember, in to kind of keep that clinical context. I was trying to remember the load they used in that paper. I was about to ask that, so I'm glad you brought that up. Was it 20 or 30%? I don't remember.
I think, I mean, their typical is somewhere in that 20 to 30%.
Yeah.
I mean, it
Yeah.
may be up to 40%, but not higher than that. And there was, 40 to 50% pressure was just as good as
Just as
80
good
to
as 90.
90%.
Yeah.
Yeah, for musculoskeletal activity and strength and hypertrophy.
but
Johnny, on this, on the vascular conductance side of things, I lack a little bit of context on exactly what that is. Do we consider that an angiogenic response, or is it just an improvement in the efficiency of the existing system? What does it tell us specifically?
yeah, and I'm not an expert on vascular conductance, but it's basically the improved fluid flow that you see. The exact definition of conductance. So you're measuring, does that fluid flow improve throughout the vessel, and so that's what they found there.
So it could be a muscle hypothesis type thing, like Larry Cahalan was talking about weeks ago, or
Mhm.
or it could just be something of the existing vasculature as well. So,
Right.
Yeah.
And this really begs the question again, and I think the trial might be happening. If this is true and you improve conductance, you improve this angiogenic response along with it, the peripheral arterial diseases. This is a prime target, and then we're saying in those populations, all right, I think we might have to go higher pressure, right? You might build them up to it, but the high pressure might be the true adaptive changes that we need to see. And again, in the upper extremity, it might be the same thing. If this is a condition where I'm trying to get more of a vascular conductance and angiogenic response, well, we might have to look at more like an IPC type, high pressure type model with this in the upper extremity, if that's what the problem is. And, we're talking about like a fracture, or, the question's been, can you arterialize a AV fistula for someone who is going to go into dialysis? So can you change that vein to an artery so that they can take the dialysis needle faster? It takes like 6 weeks. Well, can we increase pressure and get a response faster so that it arterializes quicker, so someone who really needs dialysis can get that AV fistula to arterialize faster? Or something like a scaphe fracture that has a slower healing response, and there's this angiogenic issue. Do we have to look at those from a pressure perspective, maybe? Interesting questions.
Yeah, for sure.
So just a quote here. Let me read. So it's been hypothesized that venous occlusion could increase the circumferential strain on the microvasculature, leading to the release of angiogenic factors and a greater proliferation of arterioles and capillaries. That vascular adaptation occurred only in the high pressure group at 80% arterial occlusion pressure, and not the moderate 40% AOP or the no pressure group. So I forgot to throw in, they had a zero pressure group as well. Groups tells us the following: at 15% of a 1RM is itself not mechanically able to cause an increase in angiogenic signaling sufficient to bring about adaptation. 15% of a 1RM combined with moderate 40% of AOP is not able to increase circumferential strain to a degree that would bring about adaptation. These conclusions hold for both the upper and lower body. Here's my favorite part from this paper. Past research investigating the ability of intermittent venous occlusion to treat peripheral vascular disease, as seen with uncontrolled diabetes, may need to be re-examined. And he freaking cites a BFR paper from 1937. Which is like, good on you, Grant. I want to talk to him. We just emailed back and forth recently, and I was like, dude, where did you find the 1937 JAMA intermittent hypoxia paper looking at this? And so, again, everyone is like, well, this is a new thing, or, it started in the 90s in Japan. It's like, well, no, we got papers in JAMA in 1937 that were trying to study these effects. So, any final takeaways before we move into our questions?
Yeah, I mean, to me, it's I think the interesting thing for all these is that it seems like hypoxia may be a very key factor. So obviously it depends on our exercise availability and the patient population as to, how we approach the pressure and intensity of exercise to try and make that hypoxia happen. But it really looks like, hypoxia itself may be driving a lot of the response. So that's really interesting, especially from the bone perspective and looking at these things that proliferate out, with the bone being, low partial pressure oxygen, like we talked about in previous podcasts. And, this hypoxia outside the bone maybe creates this little osmotic gradient that kind of coaxes these good things out to have a significant effect for us. So whether that's a hypoxic stimulus or chemical or mechanical stimulus, it looks like they're all pretty effective and maybe all contributing.
Yep. Cool. All right, man. So let's move into some questions here. All right. First one's from Jordan. This is kind of piggybacking on what we just talked about. Why might a doctor request no BFR until a patient is weight bearing? His specific case is this is a post-op list Frank. What precautions would there be for a non-weight bearing patient with you doing BFR?
Yeah, I don't really know why you wouldn't want to do it. I mean, I'm not sure what the thought process is for it being contraindicated. I mean, in my mind, that's even more of a reason why we should be doing BFR, because we're not really doing much else that seems very effective.
Has anyone ever had a doctor tell them don't start BFR while they're non-weight bearing in this group?
No.
No.
I've never had that.
Yeah. So I just wanted to throw it out to see if that's ever been presented before, especially after what we just talked about. I see no reason at all, and it's even more of a reason to do it. I probably need to follow up, like, why? Do you know why he did that? Was he worried about DVT or VTE or something like that? But the non-weight bearing patient is the prime BFR candidate. So those are the ones I would talk to my docs about, like, hey, you're non-weight bearings. Can we please get them in here and start this? Because they're the ones that are going through the muscle dump and the bone dump now that we see. So
right. I mean, it's just you hope that the parameters for rehab and recommendations change over time with the idea that we don't need to do anything for bone, just do nothing and let it heal. Obviously that doesn't seem to be the best case scenario.
Yeah, times have changed. We actually, and bone is going to get forced more. It finally got funded, an Alter G trial of taking fresh fractures and getting them walking immediately in limited weight bearing.
Nice.
But the bone is, the bone needs stress, and the hardware, if they do have fixation, is so robust now that most docs are pretty comfortable. Now, we don't want everyone like running out now and saying, hey, Johnny said I need to start weight bearing all these fractures. But this is a metric sponsored multi-center trial that is looking at this. One of the docs, I think it was Dan Stinner that mentioned it. He's like, if I'm worried about these fractures that we're bringing into this trial, that weight bearing is going to cause a problem, then I've got more of a problem with my surgery that I did and my technique than actually what's going on from a basic science standpoint with it. So again, I think we're going to be pushing bone a lot more and seeing a lot more of this in the future.
Is that distal fibs or?
Yeah, so it's all comers within the lower leg, not intra-articulars.
Okay.
I was going to say, on the side of just getting feedback from physicians on concern, when to start, and that sort of thing, I think we've talked about it before. The common thing we hear is, well, I want blood flow to my surgery, which I think we've kind of detailed already today. We're actually really not concerned about that. We probably improve that blood flow to that surgery. On another situation that I've had was with a multi-lig injury pre-op. The doc didn't want me doing BFR with him. He was concerned maybe there was something wrong with the popliteal artery. It seems like something would pop up before you would go into surgery if that was really a problem. But I don't know, Johnny, you've dealt with more of those. Would you have concern in that specific population, like a multi-lig knee, before they go in to do the reconstruction?
So before they go in, Well,
Yeah, so this guy actually had a lateral collateral reconstruction, and then they went back in a second time and did ACL, PCL.
and they had to fix the pop artery.
No, they did not.
Yeah.
But that was the doc said I haven't been in there, so I don't know, and so he didn't want us doing it.
Yeah.
Yeah,
I imagine that would need to be figured out much quicker.
that's kind of what I thought, but what do you do?
Now, I will say the group at our base that gave us a lot of pushback right at the start was the vascular surgeons, because we had a lot of multi-legs, we had a lot of vascular injuries during the war, and orthos on board, everyone's on board, and the vascular guys were like, not with these repairs. And so then we pushed hard enough that they came around and said, okay, you can do them with autograft repairs, but not allograft repairs, because we're not sure what this, reperfusions are going to do to the prosthetic grafts, and so we don't want to wear those down too quick. Again, which is probably a kind of silly thought if you're saying that these patients eventually are going to be lifting some heavy weights and potentially having a reperfusion, once the muscle contraction lets off and the flow goes back in. Now, and Dr. Proper here, the Air Force vascular doc, he's all on board with it and thinks this is something great with it. The vascular, or not the vascular, but he's a plastic surgeon doctor who does a muscle flaps up at Walter Reed. We've got some patients that he's done functional flaps on with these graft incorporated repair, or not repairs, but they tie the pedicle into the existing vasculature. He thinks mechanistically it makes perfect sense and probably promotes improvement with it. We'll see. We got a couple of Marines actually that are going through it right now. So I think it's changed, but I think the vascular guys might look at you with a little cross-eyed at first if they've never heard of it before. But now we're seeing there might be improvement actually in the vessel, the large vessel, as well as an overall improvement into angiogenesis. And that other question, well, I don't want to decrease blood flow because this is a graft and it's already low on blood flow. We've heard that quite a bit. I don't think we're hearing it as much anymore. It's one of those things. It makes sense when you first just kind of look at it for a second, and then when you take a step back, you're like, okay, this makes no sense. We do get this angiogenic response. It's a very slow, acute bout of hypoxia. We're still allowing some arterial inflow, and basically, let's go back to this AOSSM presentation. Okay, well then you want the bone to just kind of go south. I think that does more to graft incorporation than keeping a good dense bone almost at its baseline that it was pre-surgical. So yeah, we'll see. Hopefully with these vascular trials, one of the plastic surgeons I talked to, I think I mentioned to you guys, he was talking about he ischemic preconditions his muscle flaps by holding the artery for a little bit and releasing it with his fingers, and holding it for a little bit and releasing it to create this hypoxic effect to ischemic precondition the flap before he puts it in. That's a really cool way to go about it. Most of us are never going to get that kind of BFR on someone, but I think these guys are now looking at it like, okay, these little short bouts of hypoxia seem to be maybe powerful for what I want to do. Next question.
Looking at the animal research on IPC, that's probably the most effective way to do IPC, right? Yeah, that's what those animal studies, they clamp an artery. That's where the big effects are.
They clamp it. Yep, and there's a paper like, why aren't we seeing the changes in IPC that we see in the animals in the human models? A lot of the human models are showing changes. Some of them aren't. And there's this kind of debate, like the animals, it just seems to spare the heart. What's the deal? I think we mentioned it. There's a freaking fatal flaw in these IPC studies. And the fatal flaw is they are using a standard pressure. And it's crazy. And we discussed this. I don't know if you guys were with us. I forgot where it was, but it's like, it feels like the IPC studies are where BFR was like a decade ago. Like, okay, guys, now we got to bring this around and start standardizing it. My LOP is between 280 and 300 in my leg. And so if you use 220 on me, which is what everyone uses, I'm still not at hypoxia. The animal models are, you got to completely occlude it. And that seems to preserve the heart, the kidney, the liver, the brain. It does all this stuff. If you did it on me, I'm at partial occlusion. So I'm probably not going to get the same effect.
Right. And so I don't know if y'all caught this, but in the introduction for that Grant Mouser paper, it says the application of a single pressure is almost guaranteed to provide a different stimulus to each research participant.
Yeah.
It's like,
Yeah. Yeah.
okay,
That's so interesting.
And it's like, duh, duh from this side,
exactly.
because we've been preaching that forever. And that's the thing, there'll be a paper that comes out. It's like BFR does not work for, whatever. And it's like, okay, standard pressures. You used a pump up thing. So even if you got it to a pressure, it probably was only there for the first rep and then it just went down. So that pressure wasn't maintained. And so you can't compare that. It's just silly at this point. Now, and everyone's like, well, but some papers have shown that it does have, yeah, some of them will. There's going to be some who that was full occlusion. For me, it wouldn't be. For a lot of subjects, it wouldn't be. For some people, it's too much.
I think my patient deserves more than some. I think my patient deserves results from me.
Yeah.
I think I should control every variable that I can control.
Yeah.
Period. That's our job. That's evidence-based practice. Period.
Yeah. That's where we need to step back and look at all this stuff. I mean, even with the ACL stuff, I was having a talk at one of the conferences with a bunch of docs about it. The academy meetings here. Here's some of the things that they're looking at. Like, does an anatomic graft replacement, do the same as a non-anatomic? Moving the graft like a millimeter has less translation in the tibia and the femur, and that little bit of less translation, might reduce arthritic risk. And then it's like, okay, so you change this by like a couple millimeters, and then the patient goes back at a freaking 70% quad. At that point, does an anatomic versus non-anatomic even freaking matter? I think they're gonna have more translation because they don't have a freaking quad. So let's get that problem solved, then worry about exactly where this graft placement is. And I think this is kind of just stepping back and seeing the forest for the trees a little bit better with these things. And IPC, and that's something I think we're seeing a change now, finally, with some of it hopefully coming out forward. Oh, you guys got me on my soapbox today. All right.
You're welcome.
This question's
That's good.
This question, John. What's the youngest age patient that you perform BFR on? What guidelines would you suggest for minors? Anyways, the rest of us just saying what's up.
Zach, you can take this one because your wife was doing it when she was pregnant, right? Is that right?
Yeah, I know. So I think the youngest that I've used it in the clinic was probably around a 9-year-old, somewhere like 3rd, 4th grade. Really wasn't much of an issue with BFR. It was really limited by the attention span of the child, but he didn't seem to be able to grasp the concept of 75 reps. He's pretty much done after like 45. But either way, no adverse effects. I've actually used it. That was an upper extremity issue, and I've used it with a kid of a similar age, soccer player, with a like a hamstring issue. And had no issues. I'm currently rehabbing 2 high school kids around 14 years of age right now, and we've been using BFR chronically with them. The post-op ACLs, the one since week 2 post-op, and then the other one I started seeing at week 6, I believe.
Yeah.
So no adverse effects with it.
Yeah. What about the folks up there at Kennedy Krieger? Have you touched base with them? I think they gave you a range of things they were using it on.
Yeah. So they're the study that they're looking at specifically is with MS folks, both juvenile onset and in adults. Juvenile, I believe, is going down to 14. And then the other thing is too, like with the kid who was the youngest, like 9 years old, we used the red cuff would fit around his leg. So, and when I went up to Kennedy Krieger, we reached out to the folks at Delphi, and they basically said the size of the cuff really would determine, what you could do. And if the red cuff was even too big, say for someone's leg, they would modify one of their surgical tourniquets to be able to accommodate the limb size.
Yeah, they have a pediatric line The problem is
Yeah.
the port for those doesn't match the BFR ports. They made the surgical ones different than the BFR ones from a port, just so you couldn't take BFR systems into the ORs. So yeah, you can get a pediatric one. But yeah, that's a
Yeah,
good point.
and they told me prior to going up there that I think it's like a week turnaround, so it's a pretty quick turnaround. So
Yeah.
if it's someone that you have like a new eval and you're like, man, hey, none of the cuffs will fit, they can turn it around pretty quickly.
Yeah. So yeah, the Delphi cuffs, they're rated for pediatrics. So if they do fit properly, the way that you're taught to use them, they can be used on pediatrics. The interesting thing with MS, and I can't ever remember the name of this disease, but the stuff, Ben, that Jackie Burring's doing out there with the kid that had this new polio type syndrome that popped up with a bunch of kids having these like polio type symptoms. She had a kid come and they did it on him and made like really like amazing changes. She's got some cool pictures and videos of it. Did you say you've touched base with her, Ben, on?
Yeah, so she actually came by for that course I did in Troy, Ohio, and hung out for part of the day. And I didn't get a lot of one-on-one time to talk to her about it, but she said that they were doing some bilateral on upper extremity and bilateral on lower extremity. And, it just had some crazy results compared to the other cases. And it was only like one out of 8 cases in the whole state of Ohio. So it's not like it's a really, prevalent thing, but that's, this was a huge standout as far as the results. So it got a lot of attention from the folks wanting to look at, how are we really going to try to address this new, neuro disorder.
Yeah, no, she said she had like parents, like a support group. They were all reaching out, trying to figure out how they can maybe get their children in. So
Right.
from a neuro side, and hopefully, so Kennedy Krieger's up there at Hopkins. Hopefully, we start to get some data of, is there something that we see with someone that has a young person with a neurodegenerative type disease. So
Right.
the youngest that's been reported to me is 7. I think out in LA, that I just don't know how you can get a freaking 7-year-old to tolerate it and do it. I mean, so we don't think there's any downside to it other than, like you said, Zach. I mean, I've done some goofy stuff with my daughters with it just because they always want to try it, and they start freaking out as soon as we get start doing the LOP Doppler reading on them. So
Yeah.
Yeah.
Yeah, it was predominantly just more of like an attention span issue. We're doing the same exact thing for 6 to 7 minutes, and I want to, it would, during the rest period, they would just wander off and try to go do something else, and if I come back, man, we got to finish this.
So when they walk off, do you just increase the pressure, take it up higher?
Yeah.
Walk them in the tracks.
Yeah. It's like timeout. We just leave the cuff inflated until I feel like deflating at that point.
Yeah. Well, I trying to put some parameters to this. I think, has anyone heard of any kind of safety issues or anything like that? I mean, I've never heard of anything, and it seems like it's all just tolerance. Would you be able to get the kid to tolerate it? And obviously, from anyone coming from an athletic background, or if they got injured playing a sport, they've got some sort of idea of what that lactate stress feels like, and might do okay with it with some education. But if they have no idea what physical activity really looks like, then they're probably not going to tolerate it very well. And sounds like that 7-year-old was a gymnast, so maybe he or she was really familiar with lactate.
Yeah, it was an elite athlete already, so already had that mindset there. Our first, so we were able to see dependents. So the kids of the service members, and our first one was a 17-year-old young girl, and I remember her case specifically because she was she had torn her PCL. She's PCL deficient, and she'd been out like about 9 months. And so she was just having this issue with the anterior knee pain because that's one of the components when you lose a PCL. The lever on the patella, you have that posterior sign, and it puts a lot of stress through the patella, and that's one of the compartments that wears down quickly. And she was a high-level basketball player. I think she was going to like UCLA or something, but she was maybe going to lose her scholarship because everything was hurting her knee, and no one could get her strength back where she was rehabbing. So we started her on BFR, and so we had Biodex data on her, and just that typical like can't produce peak torque flat because it hurt on the anterior knee. And then I think it was about a 5-week, 2 to 3 times a week, completely cleaned it up. So her peak torques came back exactly. Peak torque to body weight was almost equal to the other side. And all we did was just go right at doing the quad exercise. I think we did like leg press on her and maybe like one other quad exercise. So she'd come in and do 2 things and got all of her strength back. And I heard from her mom that she was playing at her school that next year without any issues with that PCL deficient knee. So then we took it down. I think our youngest was 16. So there's no BFR pediatric or adolescent studies that are published yet that I know of, not that I've seen. So there's nothing in the literature. The only question that really has come up, and this happened from our IRB when we did the big bone repair trial and it went through and showing all these changes on bone, was what do we think it does to the growth plate? And so that's this question that, probably would be the first one to get teased out is there any changes because of all these positive bone adaptations that we're doing something to the growth plates? I don't think there would be anything, but that might be an animal model that's done first to just see what happens. I think I mentioned it before. Baby goats would be what we'd use because their physis fuse in like 6 weeks. So that's all we have on that. But yeah, if you got a young'un, make sure, number one thing, make sure mom's on board. Always, always. So don't just go blast someone's kid. Make sure mom's on board. But we have a lot of folks that are doing it, especially in the high school, middle school kind of ages. Anything else, you guys?
I think we covered it.
Good. All right. Well, once again, I bogarted all the conversation. I'm good at that. So, all right. Well, thanks. Again, if you want more information, we're at www. Oh, wait, I don't have to do the www part, right? I can just say, just use the interweb, the Google, and put in owensrecoveryscience.com. If you haven't gone to one of our courses, we'd love to have you. We have a ton. Now, just throw it out there, too. We just did one in Barcelona. And so we have the guys down there in FC Barcelona that are doing training, or not FC Barcelona, but in Barcelona that are doing our trainings for us. Just finished up a week with Susan from Canada going all through Taiwan. And so our kind of hub now is in Taiwan for trainings in Asia. So check our website if you want to do any trainings. And again, if you like us, please subscribe and go on to the Orange Recovery Science podcast and give us a rating if you don't mind. All right, fellas, get to work now. Get your asses to work. All right, later.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.